I'm not going to put a birdie tube down, but I mean, I don't have to keep
Yeah, you don't want to drop it on the floor and then say, oh, this is just a clean procedure.
So, of course, the nasogastric tube is going to come in packaging, and again, the Christmas tree may be in that packaging, may not be. You might have to get it separate. Just depends on who the manufacturer. This is Kendall, but Baxter makes tubing too. Okay. Again, when I'm looking at my tubing, I'm looking. This is a 12. Normal size we really put in, and that means the lumen. This is a little tiny one. Excuse me. Use this one for a kitty, like a school-age kitty. Adults usually get 16, 18, or larger. And again, with this type of tube, the larger the number, the bigger the lumen inside. Okay? All right. So this is like a little baby tube, but they got these special because they work better with mayonnaise. Okay, so I have this tube. I'm just going to open up the package. I'm going to keep it as clean as possible. I'm going to set up my other pieces of equipment, my catheter syringe. I'm going to pretend that that's a bath basin. I'm going to get this filled with water, and got a straw going on there. And I got some lubricant here. And really what I'm going to do is just tear the packaging open and squirt it on the side of the packaging, because I'm going to roll the end of the tubing into the lubricant. Now, in preparation for when I get the tube in, I got to hold the tube in place, because if I don't, it's nature for it to come out. So that tape I want to get ready ahead of time. So usually I just tear one piece of tape and keep it whole. Now the piece of tape, and I could lightly place it inside the packaging so I can reach it. Another technique you can do is put it on your glove. Then I need that other piece of tape, and I'm probably going to go maybe 2 inches or so, 2.5 inches. Just going to rip it. Better to use the plastic tape, the clear tape. We use paper tape on the manis because they say the plastic tape, I don't know, does something to their skin. Manicure oil of the light. All right. Now, I'm going to take this piece of tape, and I'm going to, it's hard with the plastic, the paper tape, with the plastic tape, it does it very nicely. I'm going to split it. So, in fact, I have something that looks like a fork, and I'm not going to go all the way down, okay? And I'm going to get that ready and just, again, either put it on my glove or lay it down so I can easily reach it. Alrighty, going to man my gloves. And these aren't sterile gloves, these are just clean exam gloves. At this point, I'm not going to do anything invasive, but I don't know, this person could be a little bit juicy or something, and so I'm going to be traveling around their mouth and their oral cavity. I may say, go ahead, before I pick up the NG tube, I may say, go ahead and have them either pinch one side of their nose closed and then tell them to breathe out. And I could put my finger underneath it to see which nares is straighter. Okay? The more air I feel, the opener that passage is going to be. And I can tell you, on most of the manis, it's the right. The mani's right. So this one. This one right here. Okay? All right. Now I have that lubricant there. I have my glass at the bedside. Now I need to measure to see how far I'm going to put this tube down. So I take the end of the tube, the small end, not the end with the pigtail, and I go to the tip of the nose. I place the tube there, and I go directly to the earlobe. All right? And then I'm going to hold it from the earlobe here, and I'm going to go to the xiphoid process. All right? Okay. So it measures right here. For your purposes, probably you don't want, if you have a marker pen,
Sharpie.
a Sharpie, you can put a little marker here. You'll see that there's a designation on the tubing about how many centimeters it is, but you want to mark it. One of the things you can do to mark it, that cheap tape, I'm just going to rip it in half because I forgot that I needed another little piece of tape to mark the tubing. So I'm holding it in my hand because there's all kind of little marks here, and I'm going to go ahead and tape it at that spot. And I'm going to put this loosely on here simply because I'm going to want to take it off later. Okay. Now, another thing I'm going to do, you remember in the video, they told you to kind of work this tube so it's not too stiff. All the tubes in the kids have been worked. But you want to rotate it, you want to show that you know that part of the procedure. It just makes it a little bit more comfortable. See, it's a natural curve of the tube. Then I'm going to go ahead and stick it in that lubricant and lubricate it probably about 4 or 5 inches. All right. Now I just have to put it in. I have to put this tube in some Manny lube, and we can lube your Manny's. All right. Now the patient is in bed, and they're probably at about a 30-degree Fowler's position. I'm going to have them hyperextend their neck, all right, for the first thing. So they're going to go hyperextend towards the bed, okay? Sometimes it's best to take the pillow, or another thing you can do is put the pillow down lower and have them go over the top of the pillow. Because what you're trying to do is open up that passageway, all right? So I'm going to take my tube and I'm going to enter into that right nares, and I get to a certain point that I can't go any further because I'm in back of the throat, or in back of the nasal pharyngeal. And I'm going to go ahead and turn the tube 180 degrees, okay?
Toward the other nair.
Towards the other nair. And then I'm going to have the patient, or I'm going to hold and say, can you take a sip of water? At this point in time, I want the patient, I'm always holding the tube, to go like this, to kind of do a chin, chest situation and sip the water. What happens with that? It opens up the esophagus and sort of closes off the trachea so I don't get it in. So as the patient is sipping water, I am going to go ahead and insert the tube a couple of inches. So the patient takes a sip and I insert. I'm going to rest. They take another sip and I am inserting. Ooh, my surgery yesterday wasn't good on this Manny. So they keep on taking sips. I swear I did surgery on this Manny yesterday. There we go. They keep on taking sips until I get it to the point of where I either marked it. I don't know. It's not gonna. It's not gonna go. Yeah. It's not going to go any further. So this end, the drainage, if any, would be coming from this area from the clear area, not the blue pigtail, and you have it draining in the thing. Now, I want to hold this in place, but I want to go ahead and get that cheek tape. And I'm just going to tape it. This paper tape doesn't hold so well, but your plastic tape will do nicely. And I'm just going to tape it to the side on their cheek. Now the next thing I want to do is go ahead and see if I can aspirate. So I get my catheter tip syringe, and I'm going to go into the clear plastic area. I'm just going to aspirate. Now obviously I'm not going to get anything, but we're going to pretend you did. So I got a couple of, and it looks green. I'm not going to aspirate to see how much residual because I'm putting it in because they have a problem. I already know that. So I'm going to go ahead and test my aspirate, and of course it's 3. So that is a good sign that it is in the abdomen, okay? All this time, the patient isn't choking or, they're going to be coughing and gagging a little bit, but they really, and they may cry, tears may come, because it is painful, but they should pretty much be okay. Now, I want to do what we call the swoosh. I'm going to check it. And what I'm going to do is put the stethoscope in. I'm going to take the catheter tip syringe. I'm going to fill my syringe with about 30 cc's of air. I'm going to pick up the tube, and as I am injecting the tube, I'm going to listen in that, where did you tell me the stomach was?
Upper left.
The left upper quadrant. And what I'm going to hear when it's in is a shh. And we'll say to you, I heard a swish. You're in. Okay? So in this case now, I'm going to disconnect the catheter. And if it's really draining, I'm going to go ahead and connect it to the Christmas tree or to the connector, and then I'm going to connect it to the suction, and then I'm going to put the suction on intermittent, and I'm probably going to have it in what is known as the green area. I probably don't want to go much above 120 millimeters of mercury with the suction. So this thing's really acting up right now. Okay, but it would be intermittent. I can't make the ones in the lab or this one go intermittent. So it would run for a little while, then it would shut off. And then it would go on by itself again. Okay?
And what was the split piece of tape for?
We're getting to that. This was draining, and I didn't really want to mess up my bed because my tech is already upset with me. And I don't have time to help my tech. And I just don't want that to happen. So now this piece of tape, Phyllis is just holding it here because of the fact it's a paper tape. But now I'm gonna go up here, and I'm gonna take the split piece of tape, and I'm gonna put the part that I didn't split on the nose. They talk about tincture of benzoin, and it just makes stuff sticky, but it's really smelly. And it's really hard on tender skin. So you may, if the nose is really oily, you might want to use some soap and water beforehand, or even maybe just a little bit of the alcohol and let it dry to dry it out a little bit. Because tape doesn't stick too much to oil, Okay, so I have that part.
Or the hospital may have those little stat lock things you'll see them.
To put, yeah. I'm going to go ahead and I'm going to remove this because I don't want it, and this is what happens to you. I can deal with that. I'm going to take the tube, and in the middle, all the time I'm holding it in place if the piece of tape is not. because it will gravitate out. And I wrap the piece of tape around the tube one way and the other piece the other way. Make sense? Then the patient might have a gown. If you don't do this, I mean, this is nice to do. It's not a necessary thing to do. You want to give it a little bit of tube, and then what you can do is put another piece of tape with a safety pin. The only problem is, do you fasten yours? I don't like to fasten them because I'll tell you,
You pull
sometimes
the
that
gown.
gown, it pulls it and it can pull the tube out.
Some people like them fastened though because they say that it pulls on their nose.
Right.
So I do it by personal preference. But
Patient
my
preference.
NG tubes are usually in patients that are incoherent.
They don't know.
So I usually just tape them to the ET tube.
The other thing, if they do, I have a tendency to want to put it higher, more towards the upper part, because then I can see it. And they'll be more likely to keep their gown in place up here. You know what I'm saying? So you can certainly do that. And the way you do that is just put the tape around the tube, and then and then go ahead and take the gown and pin through the tape, not the tube. Make sense?
Yep, that makes sense.
Okay, this patient was curious, and it's 2 days later, and the physician says that the patient's NG tube can come out. Again, I check my order. I go into the room and tell the patient that the physician had ordered the NG tube out. Usually they're pretty jubilant at this point, so you don't want to tell them you got to go out for something. I would probably come in with a hand towel and